Good afternoon to you all. Today we are going to discuss CNS next part, topic being Introduction to Psychiatric Disorders and Antipsychotic Drugs. Coming to the first point, that is psychiatric or mental disorders. Broadly, they are divided into three different groups: neurosis, psychosis, and affective disorders. Coming to the first point, neurosis is further divided into psychoneurosis and traumatic neurosis. Coming to the psychoneurosis, psychoneurosis is further divided into different parts, that is anxiety neurosis, phobic neurosis, obsessive compulsive neurosis, hysterical neurosis, also known as hysteria, panic neurosis, reactive depression, also known as neurotic depression. Coming to the next point, psychosis. Psychosis is broadly divided into two parts: organic psychosis and functional psychosis. Functional psychosis is also known as schizophrenia. Functional psychosis is further divided depending upon their clinical features, that is positive schizophrenia and negative schizophrenia. Based on clinical features, schizophrenia is further divided into four subtypes. These are simple schizophrenia, heavy phrenic schizophrenia, also known as buffoonish schizophrenia, paranoid schizophrenia, and fourth being catatonic schizophrenia. Coming to the next point, affective disorders. Affective disorder is further divided into three parts, that is mania, depression, depression further divided into neurotic depression, endogenous depression, and agitative depression. And third point being manic depressive psychosis. Coming to the first point, neurosis, we are going to just elucidate them. Neurosis, it is a milder form of psychiatric disorders where patient's personality is intact. There is no loss of contact with reality, but in spite of causative factors well known to the patient, he exhibits emotional disturbances in the form of aggravated defense or disproportionate anxiety. Their type: traumatic neurosis, it is a post-traumatic stress disorder. Psychoneurosis, it is an emotional or behavioral disorder arising from an unresolved conflict at subconscious level. Psychoneurosis is further divided into anxiety neurosis, phobic neurosis, obsessive compulsive neurosis. Anxiety neurosis, these are groundless, uneasiness, irritable behavior. There is fear for future. It results due to problems related to examination, to interview, to his performance related to sexual act. Clinical features of anxiety neurosis are anxiety, sweating, epigastric distress, tremors, dizziness, congestion in chest, and hyperventilation. Next point, phobic neurosis, fear from crowd, fear of isolation, fear of unknown causes. Third point, obsessive compulsive neurosis, it is a state when a person undertakes certain acts repeatedly. Examples: washing hand for 20 times per day. Next point, hysterical neurosis, hysteria. It is a situational and always in the presence of others. The person's symptoms mimic those of physical diseases dramatically, such as deafness, blindness, loss of speech, amnesia, convulsions, and pain to serve a personal purpose with no awareness of motive for doing so. Panic disorders. These are acute, episodic, intense attacks of anxiety, fear, or discomfort that appear within minutes without any obvious cause. Physical symptoms like palpitation, breathing difficulties, and sweating are found. Next, reactive depression. It is also called neurotic depression and it results due to serious physical illness or because of some inner guilt which patient cannot disclose. Sadness is the other feature. Now coming to the second part of psychiatric disorders, psychosis. Psychosis are the most severe forms of psychiatric disorders characterized by marked impairment of behavior, inability to think logically, and to understand reality. Clinical features: delusions, a false belief not altered by reasoning; illusions, misinterpretation of an actual sensory impulse; misinterpreting a bulb for fire, a string for a snake; hallucinations, a false perception without any stimulus. It is further divided into different types: auditory, visual, olfactory, and tactile hallucinations. Auditory hallucinations. Patient hears some noises even though no sound is produced. Patient looks something although there is no object before their eyes. Patient smells something even in absence of any smell. And patient feels some worms are moving on their legs even though there is no worms or there is no any tactile stimulus. Psychosis is broadly classified into two types. Organic psychosis, it occurs due to some organic diseases. Example: cerebral infection by virus, rabies, encephalitis, or traumatic injuries due to trauma or due to heavy metal poisonings like mercury, lead, or due to chronic alcoholism characterized by dementia, disorientation, and disordered behavior. Schizophrenia, psychosis without any organic etiology, resulting mainly from dopaminergic overactivity in limbic frontal areas, although role of other neurotransmitters cannot be ruled out. Schizophrenia is divided into two types depending upon symptoms. That is positive schizophrenia, clinical feature being delusions, illusions, auditory hallucinations, thought disorders, aggressive behaviors. Negative schizophrenia, clinical features being poor concentration, social withdrawal, emotional blunting, lack of motivation and memory. Schizophrenia is of four types: simple schizophrenia, hebephrenic or buffonist schizophrenia, paranoid schizophrenia, and catatonic schizophrenia. Coming to the simple schizophrenia, clinical features: early onset of age, decrease in activity, thinking ability, and emotions. Self-neglect is observed by his friends and family members. Conversation is fragmentary, answers a few but abruptly. Delusions are other features and mild hallucinations. Second types have a phrenic or buffoonish schizophrenia. It occurs in adolescence. Deranged personality distinguished by idiotic or buffoonish euphoria. Patient may act like buffalo or like an emperor. Severe thought disorders, auditory hallucinations are also present. Paranoid schizophrenia onset occurs after 30 years of age usually. Fixed delusions like pride and suspicion is the common features. Catatonic schizophrenia, it presents with acute destructive excitement and may show bizarre acts and postures with persistent stupors. Prognosis is poor. Now coming to the pathogenesis of schizophrenia. There are so many pathogenetic factors. First being genetic predisposition, 10% risk in first degree relatives, while 50% in homozygotic twins compared to 10% for dizygotic twins. Next, point dopamine hypothesis. Increased dopaminergic activity confirmed by positron emission tomography PET showing increased DA receptor density in schizophrenic patients. Post-mortem brain studies of schizophrenic patients reveals increased receptor density. Drugs increasing the central DA activity precipitate or aggravate schizophrenia. Most antipsychotic drugs act by blocking postsynaptic dopaminergic 2 receptors in mesolimbic frontal system. Increased levels of homovinylic acid, a metabolite of dopamine, in CSF, plasma and urine. Next causative factors, that is 5-hydroxytryptamine 2 receptor agonist like LSD produces hallucinations and sensory disturbances similar to those occurring in psychosis. A typical antipsychotics like clozapine, olanzapine are 5-HT2A antagonists. Next pathogenetic factor is glutamate NMDA receptors underactivity that is responsible for negative schizophrenia. Coming to the next point, affective disorders. It is a disorder of mood. It may manifest as mania, characterized by excessive desire, craziness with pathological ambitions and excitement, no delusions. Patient violently opposes any kind of interference with pursued speech. Depression, it is a mood disorder that causes a persistent feeling of sadness and loss of interest. It is of following types. Neurotic depression is a reactive depression. Endogenous depression, onset at any age. There is suicidal or self-destructive thoughts, insomnia, anorexia, weight loss due to deficiency of 5-hydroxytryptamine, norepinephrine, dopamine in the brain. Agitative depression, clinical features being angry outbursts, disruptive or impulsive behavior, excessive talking or movement, difficulty in sitting still, shuffling the feet, tension, anxiety, irritability. Next, manic depressive psychosis. It is a bipolar disorder. Mood shifts between depression and mania in an alternating cyclic fashion. Before starting classification of neuroleptic drugs, we should discuss some historical or old terms not used nowadays. In the past, antipsychotic drugs were called major tranquilizers, and there was another minor tranquilizer term used for anxiolytic sedative drugs. In USA, presently antipsychotic term is used to denote drugs which are used in the treatment of schizophrenia and other agitated states. Although there are some types of psychosis in which these drugs are not effective. In Europe, term neuroleptics are used to denote those drugs which have antipsychotic action as well as extrapyramidal side effects with the same therapeutic dose. But this term is also not complete because there are some antipsychotic drugs belonging to atypical groups like clozapine, olanzapine, etc. that have antipsychotic actions but negligible extrapyramidal side effects. So these days, neuroleptic and antipsychotic terms are used interchangeably. Neuroleptic drugs are divided into broadly two types: classical or typical neuroleptics, and second being novel or atypical neuroleptics. Classical or typical neuroleptics are further divided into different groups: phenothiazines, thioxanthines, butyrophenones, and miscellaneous groups. Coming to the phenothiazines, these are further divided into, depending upon their structures: aliphatic tertiary amine side chain, example being chlorpromazine and triflupromazine; piperidine side chain containing molecules, example being thioridazine; and piperazine side chain having molecules, examples being trifluperazine, perfenazine, fluphenazine. Next group, thioxanthines include flupenthixol, thiothixane, jaclopenthixol. Next point, butyrophenones, examples being haloperidol, benperidol, droperidol. Miscellaneous group contains timozide, penfluridol, molindone, loxapine, sulpiride, amisulpiride, and ramoxypride. Second group, novel or atypical neuroleptics. Examples are clozapine, olanzapine, quetiapine, zotapine, risperidone, ziprasidone, paliperidone, aripiprazole, sartinadol, tenapine, and lurasidone. Now coming to the next group, schematic and symbolic description of relative affinities of antipsychotic drugs for different receptors. First group being typical neuroleptics. First being phenothiazines, example being chlorpromazine, which have more affinity for D2 and alpha 1 receptors than affinities for 5-HT2, D1 and M1 receptors. Second being thyroidazine, also belonging to phenothiazine group, which has most affinity for alpha 1 than for D2, 5-HT2 and M1, and least affinity for D1. Third drug, flupentixol, belonging to thioxanthine group, shows most affinity for D2 as well as 5-HT2 than that for alpha 1 and D1. Coming to the next drug, haloperidol, belonging to butyrophenone group, shows most affinity for D2 and then affinity decreases in the order for alpha 1, 5-HT2 and D1. Coming to the next drug, sulpiride, belonging to miscellaneous group, shows affinities in decreasing order for receptors D2, D3 and D4. Next drug from miscellaneous group is pimozide, which has highest affinity for D2 and then its affinity decreases for 5-HT2 and then for D4. Coming to the next drug of miscellaneous group, molindone, which shows affinity for D2 which is more than that for 5-HT2A. Now coming to next group, atypical neuroleptic drugs. Following drugs with their respective receptor binding affinity for different receptors which are responsible for their therapeutic as well as adverse effects. First drug, clozapine, has receptor affinities more for 5-HT2A and D4 than for alpha 1, D1, D2, H1 and M1 receptors. Next drug being olanzapine, which has most affinity for 5-HT2A than for D4 and has more affinity than for alpha 1, D1, D2, H1 and M1. Next, risperidone, which has more affinity for 5-HT2A than for D4, D2, alpha 1, H1 and M1. Next drug being quetiapine, which has more affinity for alpha 1 than for 5-HT2A, D2 and M1. Next drug, aripiprazole, is comparatively a new agent. It does not block central D2 receptors, rather it has partial agonistic action on D2 and 5-HT1A receptors, which is more than its antagonistic action on 5-HT2A and which in turn has more antagonistic action than that on alpha 1 and H1. Next drug is ziprasidone and palperidone, which have more affinity for 5-HT2A than that for D2, alpha 1 and H1 receptors. Next drug, sertindole, has more affinity for 5-HT2A than that for D2 and alpha 1. Next drug, zotapine, has more affinity for D1 and D2 than that for 5-HT2A and which in turn has more affinity than that for alpha 1, H1 and M1. Next drug, acinapine, has more affinity for 5-HT2A than that for D2, D3 and D4, in which in turn have more affinity than that for alpha 2 and alpha 1. Next drug, lurasidone, has affinity for 5-HT2A and 5-HT7, which are more than that for D2. It has also partial agonistic action on 5-HT1A receptor, and at the same time it has no antagonistic action on M1 and H1 receptors. Now coming to the next point, classical antipsychotic drugs. The prototype drug being chlorpromazine. It has blocking, decreasing and depressant effects on the different sides of the brain. On the cortex, it lowers seizure threshold, so it can precipitate convulsions in untreated epileptic patients. It blocks dopamine receptors in the basal ganglia to produce extrapyramidal side effects. It blocks more D2 receptors than D1 receptors in the mesolimbic, mesocortical, mesofrontal pathways projecting from substantia nigra to limbic system and controls behavior. Has antipsychotic effects, blocks dopamine receptors present in the pituitary and hypothalamic area to increase prolactin secretion, and due to this gynecomastia, galacturia is produced. It also inhibits release of LH and FSH, and due to this amenorrhea is produced. It inhibits D2 receptors present in the CTZ, and due to this antiemetic effect is produced. On muscarinic receptors, it has anticholinergic effect to produce blurred vision, dry mouth, decreased sweating, decreased secretion, urinary retention and constipation. On alpha-1 adrenergic receptors, it produces, by its action on the alpha-1 adrenergic receptors, it produces nasal stuffiness, hypotension, tachycardia, palpitation, also direct depressant action on myocardium. Due to blocking of H1 antagonists, it produces sedation, antihistaminics and antipruritic effects. Look at this diagram showing mechanism of action of chlorpromazine. It blocks dopamine receptors in the basal ganglia to produce EPS, in the limbic area to produce antipsychotic effects, in the pituitary and hypothalamus to produce prolactin release, leading to gynecomastia, galacturia and amenorrhea. It blocks dopamine receptors in the CTZ to produce antiemetic effects. It blocks antimuscarinic receptors to produce anticholinergic effects and results in blurred vision, dry mouth, decreased sweating, decreased secretion, urinary retention and constipation. It blocks alpha-1 adrenergic receptors to produce nasal stuffiness, hypotension, tachycardia and palpitation. It blocks H1 receptors to produce sedation, antihistaminic effect, antipruritic effects. Now look at this diagram representing mechanisms of action of some antipsychotic drugs. Here sites of action of antipsychotic agents and lithium has been shown. Following exocytic release, dopamine interacts with postsynaptic receptors are of D1 and D2 types. are presynaptics, D1 and D3 autoreceptors. Termination of DA action occurs primarily by active transport of DA into presynaptic terminals via the dopamine transporter, with secondary deamination by mitochondrial monoamine oxidase enzyme. Stimulation of postsynaptic D1 receptor activates the GS-adenyl cyclase cyclic AMP pathway. D2 receptors couple through GI to inhibit adenyl cyclase and through GQ to activate the phospholipase CIP3 calcium ion pathway. Activation of the GI pathway can also activate potassium ion channels, leading to hyperpolarization. Lithium ion inhibits inositol phosphate breakdown and thereby enhances its accumulation and secondly calcium ion mobilization, protein kinase C activation, depletion of cellular inosine. Lithium may also alter release of neurotransmitter by a variety of putative mechanisms. D2 like autoreceptors suppress synthesis of DA by diminishing phosphorylation of rate limiting TH and by limiting DA release. In contrast, presynaptic A2 activate the adenyl cyclase cyclic AMP protein kinase A pathway and thence TH activity. All antipsychotic agents act at D2 receptors and autoreceptors. Some also block D1 receptors. Stimulants agent inhibit DA reuptake by dopamine transporter, thereby prolonging the dwell time of synaptic DA. Initially in antipsychotic treatment, DA neurons release more DA, but following repeated treatment, they enter a state of physiological depolarization inactivation with diminished production and release of DA. In addition to continued receptor blockade. Coming to the next point, therapeutic usage of antipsychotic drugs. There are so many different indications. First being psychiatric indications of antipsychotic drugs. In schizophrenia, drugs indicated are chlorpromazine, thioridazine, flufenazine, haloperidol, pimozide, loxapine, sulpiride, aripiprazole, clozapine, olanzapine, risperidone, and quetiapine. Look at this slide. Here dosage and dosage schedules of each drug is well illustrated. Please go through it. Other indication of psychiatric indication is drug-induced psychosis, delusion associated with LSD or amphetamine. Third, schizoaffective disorders are the other psychiatric indications of antipsychotic disorders. In schizoaffective disorders, psychosis and mood diseases, mood changes are found. And in this particular case, along with antipsychotic drugs, mood stabilizing drugs like lithiums, when prescribed together, give best result. Coming to the neuropsychiatric indications of antipsychotic drugs. These are Tourette syndromes. Clinical features of Tourette syndromes is involuntary movements, that is tics, grunts, that is slow and rough voice and vocalizations. Treatment of Tourette syndrome is by haloperidol pimozide. Although pimozide has side effects that prolonged QT interval in ECG. Other indication, Huntington's disease. Clinical feature, chorioathetosis plus dementia. Treatment, haloperidol and chlorpromazine. Other non-psychiatric indications are as anti-emetic, pre-anesthetic medications and intractable hiccup. Coming to the adverse effects of antipsychotic drugs. First being CNS side effects. These are sedation, psychomotor impairment in high doses such as confusion. Tolerance develops to the sedative and ANS side effects but not to antipsychotic action. Perioral tremors known as rabbit syndrome. Rapid chewing movements and treatment of this rabbit syndrome is anticholinergic drugs like trihexyphenidyl and some anti-Parkinsonian drugs. Tardive dyskinesia occurs late after years of treatments. Clinical features, involuntary orobuccal lingual dyskinesia and neurolept holidays. It is a neuroleptic free interval in the treatment of schizophrenia during a period of 1 to 2.5 years of neuroleptic regimen in schizophrenic patients. When after every 6 months, when neuroleptic drug is withdrawn for 6 weeks, it is observed that patient improvement continues with a smaller maintenance dose of neuroleptics after that period. Neurolept holidays plus GABAergic drugs give better result in the treatment of tardive dyskinesia. Treatment, diazepam 40 mg per day, clozapine and olanzapine. Other neurological side effects are dystonia. Clinical feature, spasm of muscle of tongue, face, neck and back. And treatment is by diphenhydramine and promethazine. Akathisia is the other side effect, which is uncontrollable motor restlessness without any involvement of anxiety. Treatment is propranolol and diphenhydramine. Parkinsonism is the other neurological side effect of antipsychotic drugs, and their treatment is withdrawal of drugs temporary as well as anti-Parkinsonian drugs. Next, neurolept malignant syndrome, NMS, is the other important neurological side effects of antipsychotic drugs, which is an emergency. Common with fluphenazine and haloperidol, not seen with atypical antipsychotics except xenapine. Clinical features, hyperpyrexia, muscle rigidity, autonomic instability with fluctuating BP, increased myoglobin and increased creatine kinase reflecting muscle damage. Treatment, stop antipsychotics and give dantrolene, diazepam and bromocriptine. Now coming to the ANS side effects of antipsychotic drugs. Due to alpha-adrenergic blockade, clinical features are postural hypotension, tachycardia due to vagal inhibition, loss of libido and delayed ejaculation. Muscarinic effects, clinical features, dryness of mouth, constipation, urinary retention, disturbed accommodation. Clozapine produces hypersalivation. Endocrine side effects of antipsychotic drugs. Due to blockade of DA receptors in mammotropes, hyperprolactinemia, that leads to galactorrhea and gynecomastia. Inhibition of FSH-LH produces amenorrhea and inhibition of ovulation. Altered eating habits, miscellaneous side effects being jaundice, photosensitivity, corneal opacity and retinal pigmentation, epileptogenic effects and pyroclothermic effects. Look at this table showing major antipsychotic drugs with their advantages and disadvantages. Butyrophenone groups, haloperidol, advantage fewer anticholinergic side effects, no jaundice, depot injection available, high potency, no weight gain. Disadvantage severe extrapyramidal syndrome and tardive dyskinesia. Coming to the next group, that is miscellaneous group, drugs being pimozide and sulpiride. Their advantages are longer acting, high potency, fewer anticholinergic side effects, good for maintenance, lesser extrapyramidal syndrome than haloperidol, lesser sedation, lesser autonomic side effects. And disadvantages are moderate risk for extrapyramidal syndrome, prolongation of QT interval, hypokalemia. These are especially of pimozide, and disadvantage of sulpiride are gynecomastia due to increased prolactin level, poor absorption. Amisulpiride is similar to sulpiride, but it is long acting, better absorbed and more safe. Now coming to the atypical neuroleptics groups. First drug being clozapine, its advantage being good for positive and negative symptoms and for resistant cases, high potency, least extrapyramidal side effects. Its disadvantage being granulocytosis, weight gain, hypersalivation, risk of diabetes mellitus, low seizure threshold. Next drug of this group being olanzapine, and its advantage is like clozapine, and its disadvantage being weight gain, risk of hyperlipidemia and new onset diabetes mellitus. Third drug being risperidone, advantage being high efficacy, no extrapyramidal side effects in low dosage, and other features are same as olanzapine. And its disadvantage being extrapyramidal side effect in high dosage, weight gain, gynecomastia, postural hypotension and cardiac arrhythmia. Now coming to the next drug, quetiapine. Its advantage is high efficacy, no extrapyramidal side effects in low dosage, but is less potent. Its disadvantage is postural hypotension, dry mouth, weight gain, cataract formation, priapism, short half-life, so BD dose. Next drug being ziprasidone, and its advantage is like that for olanzapine. There is no weight gain, depot injection available. Disadvantage being QTC prolongation in ECG, diarrhea or constipation, less risk of diabetes mellitus. Next drug is aripiprazole. Here no extrapyramidal side effect. These are the advantage. No weight gain, no endocrinal side effects, no ECG changes, longer acting, high efficacy. And disadvantage is unusual due to partial agonist action may account for lesser side effects. Now coming to the next drug, zotapine. Advantage being no extrapyramidal side effect, less sedation. And its disadvantage is weight gain, cardiac arrhythmia in high dosage. Other drug is Sertindol, and its advantage is less EPS and longer acting. Disadvantage is weight gain, ventricular arrhythmia, and nasal congestion. Another drug is acinapine, and its advantages are less EPS, less weight gain, and disadvantages are sublingual BD dosage 5 to 10 mg, sedation, oral hypothesia, postural hypotension, and NMS. Next drug is lurasidone. Advantages are less EPS, less weight gain, less risk of tardive dyskinesia, and disadvantages are less risk of diabetes mellitus, hyperlipidemia, and QTC prolongation. Phenothiazine group of drugs, these are chlorpromazine, and advantage is very cheap, not expensive, and disadvantage is serious autonomic and endocrinal side effects, low potency. Thyroidazine, low incidence of EPS and no jaundice are the advantages, while disadvantages are cardiac toxicity and cardiac arrhythmia, low potency, no intramuscular depot injection available. Fluphenazine, advantage being high potency, depot injection available, no jaundice, and disadvantages are high incidence of extrapyramidal syndrome and tardive dyskinesia. Next drug group is thioxanthines, and drug being flupentixol. Advantages are moderate incidence of extrapyramidal syndrome and tardive dyskinesia, high potency, depot injection available. Disadvantages are not suitable for long-term use, restlessness, gynecomastia. Thank you.